Okay, guys, welcome back. Let's talk about costochondritis today. This is a common condition. Many of the time, you see the patients worried about the pain in the chest, and especially they get anxious when it's a matter of the chest because of the severity and the gravity of the ischemic heart disease problems. So they are most of the time worried about the heart problems, and that's why they can get anxious. So this is something that can be seen in multiple situations, especially in history, with the history of chest trauma and any chronic illnesses in fibromyalgia or uh, rheumatoid arthritis or many other inflammatory conditions. This is easy to treat, however, a good history is required. So, when you take the history, the patient's symptoms are quite self explanatory. They are not as severe as you would see with the chest patient coming from the cardiac events. The patients usually in the costochondritis they feel tender in the chest. The chest pain can be in the middle or all over the chest. However, it is more localized. The pain that goes towards the neck, towards the shoulder, or makes a patient feel sick, that are the worrying pain. So, in those cases, we should be worried about the myocardial infarction or any other lung pathology. However, if the patient reports you pain just in the middle of the chest, feel tender, the pain may get worse when they lie. It does not have any particular relation to the activity, to the exertion. The patient feels a pain constantly when this pain starts. It can last for days to weeks, and sometimes it can last for months. It is important that we take the detailed history of the patient, find out if they had any chest trauma, find out if they have any previous medical illness, including fibromyalgia or rheumatoid arthritis. These are the important clinical conditions which may be related to the costochondritis. Talking about the examination, most of the time the examination is normal, apart from the patient feels tender all over the chest. And about the investigations, most of the time they do not need any investigation, and it is quite clinical diagnosis. However, based on the age and based on the risk factors, it is important that you always keep in your mind that you have to rule out many other conditions, including pulmonary embolism as well as ACS, or as well as aortic dissection. So, based on the situation, based on the other factors, including the age of the patient, family history of ischemic heart disease, previous history of ischemic heart disease, high cholesterol, these are the risk factors that will be more suggestive of the cardiac event instead of costochondritis. However, if there is no risk factor or there are only a few risk factor and the patient is young, then most likely diagnosis can be costochondritis. You need to find out the signs and symptoms, especially the symptoms are prolonged chest pain, constant chest pain, and it is dull. It is not as sharp as you would see the patients coming with the chest pain from the ischemic heart disease or the pulmonary embolism. Based on your settings where you are seeing the patient, we may need to assess the patient as well as also how the patient has presented. If there's anything worrying, then we need to investigate thoroughly, including the cardiac enzymes as well as chest x-rays. However, chest x-rays are not normally recommended for costochondritis. Now, let's talk about an example of a scenario. There you go. Now we have a patient who is 27 years old, and he is called Mr. James. Let's see what we have in the background. This is a patient story. James has chest pain, and he he had a fall from the bicycle 3 days ago, and the chest pain is more towards the right upper side. For the patients, chest pain is chest pain. They don't know exactly about the radiations, about the other symptoms and the characters of the chest pain. So as a doctor, this is our duty to rule out and rule in certain diseases. The pain increases on inspiration. It is 4 out of 10, and these are suggestive of non-cardiac chest pain. The patient has von Willebrand disease since childhood, which is very well controlled, and he is allergic to penicillin. He lives alone, he is a teacher, and he does not smoke or drink. Family history is negative. The patient is worried about the heart attack. The patient is complaining of the pain on the right side and worried about if he had the heart on the right side. So there may be variable concerns depending upon what you find. However, the nature of the problem remains the same. So in this patient has come to you in the A&E, and you are working there, and he is complaining of the chest pain. As you know, your task says talk to the patient, take history, assess him, and discuss the management with the patient. So after taking the detailed history that includes the Socrates for the pain, site, onset, character, radiation, anything exaggerating, anything alleviating the pain, and any time, any particular time, and the severity of the pain. These are the features that we need to ask in the history. That is very, very important. Then ask about associated symptoms, any cough, any breathing problem, and any fever. Like those kind of symptoms are very, very important. So asking about family history is very important. Asking about the history of trauma, history of injury is extremely important. Risk factor, always rule out the risk factor. If your patient reports the symptoms related to the costochondritis, we do not need to do chest x-rays. However, I suggest you to do all the routine investigations, including troponin as well as 12 lead ECG. If they all come normal, then the treatment is very simple. Ibuprofen, paracetamol, any over-the-counter drugs for the pain. And in the longer term, the patient may need steroid injections sometimes, which may be helpful. However, when you explain the condition to the patient, explain to him that it will take some time, as well as also tell them the red flags and safety netting is very, very important. Ask them to come back if they start feeling unwell, if they start getting the pain while they breathe in or breathe out, if the pain starts going towards the neck, towards the shoulder, and they start feeling unwell, nausea, vomiting. So these are the worrying symptoms. The patient should be aware of them so that he does not keep sitting at home with the assumption that this is just a costochondritis. It may be ACS the next time. So inform the patient and make sure the patient understands and he is able to relay the information back to you. This is all about it, and this scenario is very, very important. Make sure that you go through this and keep practicing. Best of luck. Thank you.